Good morning, everybody. I'm going to introduce this session. This is the recommended immunization schedule for adults 19 years and older. And so just to remind you, I think of it as the footnotes group, but I know it's more serious than that. So every year, this schedule is updated. It represents the currently approved ACIP policy and is designed for implementation of those policies. The updates are approved by several specialty societies, including those on the slide. And then the schedule is published in the MMWR as an announcement, and then also it is published in the Annals of Internal Medicine in its entirety. So the updates for the 2018 adult immunization schedule will largely be around the zoster vaccination recommendations, which we approved yesterday, MMR vaccination recommendations, also reflecting yesterday's discussion, or vote, I should say, and then the adult immunization schedule format changes, which hopefully people will be very excited about. And then finally, just a thank you to the work group, which is a very hardworking work group. Especially thank you to Paul Hunter, who is the other ACIP member on the committee, who reads every footnote twice. Thank you. As well as the ex officio members and the consultants, and then we have a long liaison group who's very active. And then a special thank you as well to the CDC support, especially our fearless leader, David Kim, who puts up with lots of our crazy nonsense. Thank you very much.
We drafted the proposed 2018 adult immunization schedule to include the recommended use of zoster subunit vaccine and mumps-containing vaccines in mumps outbreak settings. Here's a quick recap of the zoster vote taken yesterday. Number one, the zoster subunit vaccine is routinely recommended for adults 50 years or older. Two, the zoster subunit vaccine is recommended for adults who previously received the zoster live vaccine. And three, the zoster subunit vaccine is preferred over the zoster live vaccine. You also recommended the use of third dose of mumps-containing vaccine in mumps outbreak settings as determined by public health authorities. I will walk us through these changes in the adult immunization schedule in a moment. I will also review the format changes in the proposed 2018 adult immunization schedule. It's still 6 pages. The cover page, figures 1 and 2, which represent recommended vaccination by age and by medical condition and other indications. 2 pages of footnotes, and the table of contraindications and precautions for vaccines. This is the proposed cover page. The cover page now contains additional information on special populations. Pregnant women, adults with functional and anatomical asplenia, and adults with immunocompromising conditions. The intent was to consolidate this information so that the details are not repeated multiple times in the footnotes. Also revised is the abbreviations for vaccines. The list is now organized by the order of the vaccine's appearance on the schedule to keep the vaccines together. This is the working figure 1, the recommended immunization schedule for adults by age. Of course, the big change is with the zoster vaccine. Instead of the ZVL role for age 60 or older, a role for HZSU or ZVL is created for 50 or older. The indication bar will have the text 2 doses of HZSU and in parentheses, or 1 dose of ZVL if age 60 or older. There are other minor changes. Last year, the ACIP recommended a 2-dose HPV vaccination series for adolescents and young adults based on their age at first dose. To reflect that recommendation, the text in the indication bar for HPV has been changed from 3 doses to 2 or 3 doses depending on age at series initiation. Moving down to the men ACWY row, the 2018 adult immunization schedule removed the meningococcal polysaccharide vaccine because it is no longer on the market. In the indication bar, the text has been revised from 1 or more doses depending on indication to 1 or 2 doses depending on indication, then booster every 5 years if risk remains, to more accurately reflect ACIP recommendations. Lastly, on Figure 1, the order of TD and Tdap has been reversed to emphasize Tdap in adult immunization. In addition, the indication bar for Tdap or TD now states 1 dose Tdap, then TD booster every 10 years. The previous text, substitute Tdap for TD once, was not quite accurate as the dose of Tdap for adults was meant to be given at the first opportunity and not wait until a TD booster is needed. This is a working draft of Figure 2, the recommended immunization schedule for adults based on medical condition and other indications. As in Figure 1, Figure 2 needs to incorporate the zoster subunit vaccine. At the moment, the indications and contraindications for the zoster subunit vaccine will mirror the indications and contraindications for the zoster live vaccine. The role for zoster vaccination is subject to change as we learn more about the zoster subunit vaccine. This is the working draft of the footnotes. This is page 1 and page 2. Though it's hard to tell on the screen, each footnote is presented in more of a bulleted format as opposed to a paragraph format. The work group worked very hard to consolidate the information, remove outdated or less pertinent information, and to keep the footnotes brief and concise. Overall, the length of the footnotes for 2018 decreased by about 25%, and there's a lot more white space compared to the 2017 version. Moreover, we compare the adult schedule side by side with the child and adolescent schedule to make the transition as smooth as possible. Here's the revision on the zoster vaccination footnote. The white box on the left contains the footnotes from the 2017 schedule. The yellow box on the right contains the proposed 2018 footnote. Under general information, the footnote states, administer 2 doses of herpes zoster subunit vaccine 8 weeks apart to adults age 50 years or older, regardless of past episode of herpes zoster or past history of zoster vaccine live. Adults age 50 years or older who previously received ZVL should receive 2 doses of HZSU 8 weeks apart, at least 8 weeks after ZVL. ZVL continues to be an option for adults age 60 years or older. However, HZSU is preferred in this age group. In addition, under special populations, the following text has been added. Pregnant women and adults with immunocompromising conditions, including those with HIV with CD4 cell count less than 200, should not receive HZSU or ZVL. Under the measles, mumps, and rubella vaccination footnote, we incorporated the recommendation that was made yesterday. In the blue box is the text that was voted on yesterday. Persons previously vaccinated with 2 doses of mumps-containing vaccine who are identified by public health as at increased risk for mumps because of an outbreak should receive a 3rd dose of mumps-containing vaccine to improve protection against mumps disease and related complications. It's a long sentence that can be used for adults and children. For the adult schedule, an alternative may be to specify the use of MMR in a simpler sentence as in the white box underneath the blue box. Administer 1 dose of MMR to adults who previously received 2 doses of measles-containing vaccine who are identified by public health as at risk for mumps in an outbreak. Other than the zoster and MMR vaccination footnotes, there are no other footnote content changes. I mentioned earlier that we try to harmonize the footnotes in the adult schedule and the child and adolescent schedule when possible. A good example is the HPV vaccination footnote. This was important because the number of doses of HPV vaccine that an adult should get depends on what he or she got or didn't get as a child. The format and flow of information are similar in the adult and child and adolescent schedules. Last thing I want to mention about the footnotes is on meningococcal vaccination. For 2018, the footnotes on meningococcal vaccination have been reorganized to present men ACWY and men B separately. Doing so allowed the content to be shortened, as you can see here, and easier to follow. The last page of the proposed 2018 adult immunization schedule is the table of contraindications and precautions for vaccines. There are no substantive changes in the table. We will revise the 2018 adult immunization schedule draft based on your comments and suggestions this morning. If you vote to approve this adult schedule to proceed, we will share it with our partner professional organizations listed here and move it forward for approval by the CDC director. If approved, our projected timeframe for publication is early February, as in previous years. And thank you.
Thank you, and congratulations to the committee for making it a little simpler. It looks like you've made great strides. Questions and comments? Yes, Dr. Kemp.
First of all, congratulations. This is so much better and simpler, I think. One question I had on the new preferential recommendation for the subunit, how will that be indicated in the figure? Because a lot of people won't go past the figure.
So there are two figures. This will be the first figure, figure 1, based on age. So the left-hand column under vaccine, instead of ZVL, it will have HZSU or ZVL, and the age at which these vaccines are recommended is 50. So there will be a yellow bar which is recommended for routine vaccination. So within the yellow bar, the following text will be added: 2 doses of HZSU, or 1 dose of ZVL if age 60 or older. So that's for figure 1. And for figure 2, like in figure 1, the left-hand column for under vaccine will contain HZSU or ZVL versus ZVL alone. And the remainder of this will remain the same. As you can see here, HZSU or ZVL row, the row above it, which this row is supposed to replace, is only ZVL. And you see the contraindication for it under pregnancy and immunocompromising conditions and HIV infection with a CD4 count below 200. So that contraindication will remain. As will the recommendation for the other populations, as you see here, as asplenia, end-stage renal disease, heart or lung disease or alcoholism, chronic liver disease, diabetes, healthcare personnel, and MSM. They will have the same recommendation as the row above ZVL that this will replace. And the yellow bar will contain the information: 2 doses of HZSU.
I'm sorry to interrupt you, but you probably can't see the faces of the committee, and I can. And I think that language doesn't express their intention, which is to express a preference. Is that what you, yeah. So we need to go back and figure out how that language could better express the intent of ACIP, which was a preference for that subunit vaccine. That looks like the 2 vaccines are equivalent. Am I getting that correctly? Yes. So perhaps we can pause for a second and figure out if there's a way that reflects better what y'all think.
Can I make a suggestion?
Dr. Riley.
We didn't have like a lot of time to think about this last night, but I think in the picture you could just put preferred right next to the HZSU, because you can't really take it completely off of the page, because then people won't know what to do if someone's already gotten it. So I think I would just put in parentheses preferred, and then read the directions, God forbid.
Dr. Kemp?
Yeah, that would completely do it, I think. That's all that's needed.
Dr. Belongia?
Yeah, so I think just to, sort of state what the suggestion was, that it would be 2 doses HCSU, and then in parentheses preferred, and then or 1 dose CVL if age greater than or equal to 60. So that would not be in parentheses. Yes, sure.
I would also put preferred into the left-hand column after the subunit, just to make it very clear. Twice. Okay.
Dr. Savoy?
I was just confused. Which is the right abbreviation for the new vaccine? Is it this HV/SU or is it the ZVS that I think I saw somewhere else?
Based on yesterday's discussion, ZVL is a zoster vaccine live, and HZSU was what was used for herpes zoster subunit vaccine. And if there are changes to the nomenclature of the vaccines, we will certainly incorporate that.
Yeah, we'll make sure that the statement, I know that they have gone back and forth a little bit on what would be most simple and effective at clarifying the 2 vaccines, and we'll make sure they're harmonized.
Dr. Friedland?
Yes, thank you. Leonard Friedland from GSK. Just to bring to the committee's attention, in the prescribing information for Shingrix, there's only one contraindication, and that is if people have had an allergic reaction to ingredients of the vaccine or an allergic reaction to the first dose of the vaccine. Neither pregnancy nor immunocompromising conditions are contraindications, nor warnings, nor precautions. So it's not reflected as on your slide right there. Thank you.
I will defer to the zoster working group for comments on that.
Dr. Belongia, do you want to comment?
Well, it hasn't been addressed yet, and the work group is going to be addressing immunocompromised in the future as more data becomes available. But given that the current licensing indication doesn't have a contraindication, it seems like we should be consistent with that.
Dr. Atmar?
Could you say not indicated as opposed to contraindicated?
I'm not sure, we really can justify that right now at this point. I mean, I think it really hasn't been addressed, and so I can't see any reason to deviate from the FDA licensing indication.
Dr. Moore?
I think we could say that we've not made a recommendation for pregnancy, but that's really all we could say, because if it's not contraindicated or a precaution, then we wouldn't want to even say not indicated.
Dr. Rangel, do you want to use your microphone?
You said there won't be a lot of pregnant women over the age of 50, although I'm sure there will be a few.
Dr. Baker?
Well, I can't remember, so it's just a question. Don't we have for live vaccines in pregnancy age group precautions rather than contraindications? Don't you think we should have the same language for zoster? I mean, I agree with you. There are not many pregnant women over 50, but there are some.
Dr. Offit?
Yeah, regarding, and I'm telling you what you already know, but regarding immunocompromised individuals, those individuals are at higher risk of having shingles. And it just seems to me that while it may not be as effective in an immunocompromised person, safety is not as big of an issue. So I think, if anything, one should encourage its use in immunocompromised, certainly not discourage its use.
Thank you. Dr. Middleman?
Middleman Sam. I was just wondering if, it may have been on another table where we lost a line, but it seems like these 2 vaccines need separate lines so that you can indicate what is truly appropriate for each vaccine.
Thank you. Dr. Stevens?
No, I was just going to make the same point about immunocompromised patients that was just made. I think that's an important area. This is a subunit vaccine. It's not a live vaccine, so I don't see why we wouldn't follow the FDA-approved guidelines.
Dr. Sun.
Yeah, I just want to make a clarification on the use of vaccines in pregnancy. Unless there is a study of that vaccine in pregnant women, even though that age indication, may fall in within that age indication, it is still not considered. We will be still use in pregnant women will still be considered off-label.
Thank you, Dr. Massonia.
Not trying to get ahead of you, but I just want to. I'm a little concerned because I feel like the working group was grappling with this issue and had been planning to bring it back. Sorry. The zoster working group was grappling with this issue and had been having discussions and had been planning to bring it back at the next meeting. And so I'm a little concerned that, voting on it in the context of the schedule means we then, I think, go back and put it in the zoster statement. So I just wanted to make sure that we're having enough time to debate it. And if we need to change the schedule to give us a little more time to come back to this issue, we should, because I understood that you guys were going to come back to it.
Right. I think I agree. I think we need a little more time to address this. I do see a difference between the pregnancy and immunocompromised has been pointed out. And I think the pregnancy is pretty clear that we'd say it's not recommended in pregnancy. But for immunocompromised, I think the work group can come back with some recommendations and in terms of that. But I don't know that we're prepared to do that right now.
Yeah, I think we're unfortunately stuck in this bind where we need to figure out how to move forward with the schedule, but we haven't quite resolved this issue. And I don't think we can have that discussion right now. So I think we have to have a solution that we can put on the schedule to move forward, unless we want to hold the schedule until our next meeting. And I don't think we can do that. A couple of other comments, and then we'll try to come to closure on this. Dr. Duchin?
Thank you. I agree that the subunit and live virus vaccines should be dealt with separately in the schedule, and perhaps consider something like not currently recommended for the subunit vaccine in pregnancy and immunocompromised. Thank you.
Thank you. Dr. Schaffner?
Bill Schaffner, National Foundation for Infectious Diseases. I guess I'm reinforcing Dr. Stevens. There are many, many people who are immunocompromised older than age 50, and many of those providers have followed the development of this vaccine closely. They will wish to start immunizing their patients, even though we don't have information of exactly how effective, under what circumstances the vaccine will be. They will regard it as harmless in the sense that there are few, if any, safety issues, but the benefit is potentially large.
Thank you. Dr. Freihofer?
Sandra Freihofer, American College of Physicians. I want to point out that yesterday when the vote was taken, it was specifically ACIP voted on for immunocompetent patients. So it would seem that, there is a white box there for no recommendation. So perhaps there need to be two lines, and for the HCSU, just have no recommendation until the work group has had time to address that.
Yeah.
Thank you. Dr. Weber?
I'd like to turn to a different issue. On the Tdap, the wording of the footnote says, administered to adults with no previous dose of tetanus-reduced diphtheria toxoid or cellular pertussis vaccine as an adult or child. So that would mean that since we give Tdap to people 11 to 12, potentially as young as 7, that healthcare workers for whom Tdap is recommended would not be given it when they become a medical student or a dental student if they had Tdap as young as a child per the schedule. But the recommendation in the healthcare guideline, the ACIP guideline says for healthcare personnel, regardless of age, should receive a single Tdap as soon as feasible if they've not received a previous Tdap. I just want to clarify that means that once you receive your Tdap at age 7, 8, 9, 10, even if you're a healthcare provider, you never need a Tdap as an adult. Or for that matter, you're a grandparent with a young child at home.
That is correct.
So that will be corrected, is that the?
Yes.
That is correct, and we'll correct it in the.
We'll include the additional language.
Sorry, I don't understand what you're talking about. Can you say that more explicitly?
David, can you read it again?
I can summarize quickly. It's just that it's to clarify that you do need a dose additionally as an adult, even if for healthcare workers specifically. Is that?
Language says you don't need a dose as adult, which means essentially we're leaving our healthcare providers without any pertussis
But we need to
protection.
change it to say that you.
The language in the actual pertussis TDAP statement says that healthcare workers need a dose regardless. So the schedule doesn't reflect the actual ACIP statement on TDAP. And so what he's asking is that we update the schedule to match what you've already voted on.
Yes.
But okay, so let me just see if I understand this correctly. If you are not a healthcare worker and an adult, and you've got your TDAP at 11 to 12, you're good. But if you are a healthcare worker and you got it at 11 to 12, you need another one.
Vaccine is not licensed for more than one dose. The discussion, and I think maybe it was a previous ACIP, which is why it doesn't sound familiar, was that because healthcare workers are at especially high risk, that they should get a dose regardless, regardless of their previous TDAP. Regardless of age, but it also means regardless of previous TDAP.
So that correction let's assume that correction is made to the schedule.
So where that correction would be made under special populations then? Not under the general information section of TDAP?
That's correct.
Okay,
Yes.
got it.
Dr. Whitley Williams.
Pat Whitley Williams, sorry, National Medical Association. I had a similar question, but I think for a provider who does not read the footnote, it can be very confusing. So I don't know if putting the actual footnote number beside where it says 1 dose of TDAP should be added, because if I were looking at this, a second dose of TDAP would be given to everybody, even though they received TDAP at 9 to 12. Sorry about my voice.
Thank you. Dr. Moore?
We were discussing here, going back to the zoster vaccine question. So I think in general, we agree with Sandy Freihofer's comment regarding leaving a blank there, a white space specifically for the subunit vaccine. The zoster vaccine live is contraindicated in immunocompromised people, and we need to maintain that indication, but just leaving white space, making it clear that it is not contraindicated. But given that we voted on the word immunocompetent in our recommendation yesterday, we can't just include the immunocompromised in that because of the way we voted yesterday.
David, can you put the schedule back up again? Thank you.
I was thinking of something along the lines of what we've done with the childhood schedule, where we've had to split a bar in half before because we had 2 different comments in the same bar. So perhaps we could do that here.
I think that would be most appropriate thing to do.
And then you could,
you could see the 2 different vaccines,
right?
And each one would have their own contraindication.
And if ZVL would be contraindicated, and HCSU, maybe the language should just say not contraindicated.
Oh, just silent.
Just
blank.
Just blank.
Leave
Okay.
it blank.
Yeah.
Let's leave it blank.
Okay, leave it blank.
Let's keep it simple. Okay, Dr. Kimberlin?
To go back to TDAP, I think I'm a bit confused. Are we saying that there are 2 groups of people in the world that are recommended to receive more than 1 dose of TDAP? One is pregnant women, and the other is healthcare providers if they previously received a TDAP. And if so, when was that vote? I missed that.
I think to clarify, the issue is that now people who did, when the vote for a healthcare worker to receive 1 dose happened, all of the healthcare workers were adults, and we hadn't been using TDAP long enough for those adolescents to age into adulthood. And
Agreed.
They technically have aged into adulthood, so because of the current footnote that says you shouldn't get one, but I think we haven't really addressed the issue of healthcare workers who already had received a dose, but we do have a recommendation that all healthcare workers receive a dose.
So
So
what,
I think this
so,
is
so am I
something-
correct to say that there are two populations that should receive more than one dose of Tdap in their lives? First is pregnant women. Second is healthcare workers who received one earlier in their lives, before they were healthcare workers. And that seems like that needs a vote.
Yeah, so that,
I think what Dr. Cohn was saying, which is the historical, how that happened essentially, and I don't think we've taken up specifically whether or not a healthcare worker gets a third dose of Tdap. I think, a second dose, sorry. But I think it's because of the way it happened, which was at the time we made the Tdap recommendation for healthcare workers, most healthcare workers had not had a previous Tdap. Now they have. And so you're correct that we may need to take that up specifically, but we have not previously. But I think we should still have the schedule show that healthcare workers get that dose, because that was the decision. I know, it's historic, right?
Yeah,
There's a limit to what we can do. We're just trying to make the schedule to reflect what we think the best recommendations are at this time.
I
And
think that's right.
we can't review each one of those recommendations.
I think that's right. I mean, the goal of the schedule working group is to make the schedule reflect the recommendations that are already written, although I agree that at times it points out loopholes that we need to think about, one of which is Tdap. But before we go to Tdap, which may be what the hands are about, can we just finish Zoster, because I'm still confused. For the subunit vaccine for immunocompromised patients, I understand 2 bars, and the subunit vaccine bar will be kept blank because there hasn't been discussion of immunocompromised populations, regardless of the fact that we understand that some ACIP members feel strongly that this is a group that the vaccine is specifically targeted to, and therefore, regardless of whether there's data, which we may or may not have, we'll just plan to bring it back in February, which may mean that it doesn't get on the schedule, but clearly would provide guidance for the people that need to recommend it. But what about for pregnant women, please? Because I am not sure if you're also saying for pregnant women, it should be blank, or if pregnant women are immunocompetent, and therefore you are saying that it's recommended. So can we just finish the Zoster before you guys argue about it?
Dr. Riley, do you want to comment on that for pregnant women?
So, I mean, I think for other things where we don't have data and there is concern, we just leave it as a white box, which is what, almost everything else is, right? Because we're saying it's not indicated necessarily. I mean, HPV is a white box, and none of us are really worried about it, or none of us obstetricians are worried about it, but it's not indicated. So I think we could leave it as a white box for pregnancy. I don't feel particularly strongly about it.
Grace just pointed out there is a contraindication for Zostavax in pregnancy. So that's clear.
Well,
but I
but
think
those
for
are
white box
live
for
vaccines.
HCSU makes sense, and that's consistent.
Okay, so just to clarify, so there's contraindication for immunocompromised people for both ZVL and subunit vaccine, and there's a white box.
No.
So would you guys like for us to move on to the childhood schedule?
Yes.
And let this group go? And I know we won't be able to show it to you, but we could at least write it out in a way so that you guys are clear about what you're voting for. And then we'll come back to the adult schedule. Does that
Good
sound
idea.
reasonable?
That's fine.
Okay, so let's move forward then in that case and go to the childhood schedule, and Dr. Romero.
So I'm here to introduce the 2018 recommended immunization schedule for children and adolescents aged 18 years and older. The members of the ACIP who are part of the work group are shown on this slide: Ms. Cynthia Pellegrini, Dr. Allison Kemp, and Dr. Peter Szilagyi, and myself. And our 9 liaison representatives are shown below that. And then to the right of that are our consultant and, of course, our leader, Candace, who's done a wonderful job in streamlining the recommendations, the footnotes, which she'll talk about shortly. This next slide shows our CDC contributors who have contributed significantly to the finished product and deserve a good deal of thanks for this. So why is this being presented? So I remind the ACIP and the audience that, members of the ACIP and the audience that we have to have approval of the proposed schedules before they are published by the MMWR in either January or February of next year, So they have to be voted on. Second of all, we have to have our liaison organizations, the AAP, the AAFP, and ACOG, also approve the proposed schedules before the 2018 publications. And I want to remind you all that no new policy is being established here. We are simply reflecting the recommendations already approved by the ACIP. Excuse me. The outline, which will be presented in detail by Dr. Robinson, will include specific work group recommendations regarding figures 2, the catch-up figure, figure 3, the high-risk figure, and changes that have been made to simplify the footnote format, making it easier to read and easier to interpret by the busy clinician. There will also be footnote changes specific to hepatitis B, influenza, and poliovirus vaccines. And then this will be followed by a discussion and vote by the ACIP committee. So I'm going to ask Dr. Robinson to please come up and take us through the modifications for your vote.
First, there's one change that will impact multiple portions of the schedule.
Just want to be sure.
From the child-adolescent schedule, Minhibrix has been removed, and the manufacturing of Minhibrix has been discontinued and all doses expired as of mid-September 2017. Mention of this vaccine has been removed from Figure 1, Figure 2, and the relevant footnotes, Hib and meningococcal vaccines. There are updates for the 2018 cover page. The table noted on the right has been added to the schedule. This is a table of vaccine types, abbreviations, and brand names for respective vaccines. Within Figure 1, the routine immunization schedule, there are no substantive changes for the 2018 schedule. For Figure 2, the catch-up figure, the maximum age for the first administration of the first dose of rotavirus vaccine has been added to the catch-up table, as well as the maximum age for the final dose in the rotavirus series. This is to provide the provider who is catching up a patient with rotavirus vaccine the information within the context of the catch-up figure. This information is also present within the footnote. Additionally, clarification has been made for the catch-up regarding inactivated poliovirus vaccine, specifically for catch-up vaccinations for persons greater than or equal to 4 years of age. We have added within the polio catch-up in the dose 2 to 3 column that the minimum interval between doses is 4 weeks if the current age is less than 4 years, and 6 months as a final dose if the current age is 4 years or older. Clarification has also been made in the bottom half of the catch-up figure, which represents catch-up vaccination of children 7 through 18 years. Within the dose 2 to 3 column, we indicate that the minimum interval between the dose 2 and dose 3 is 6 months, and a fourth dose is not necessary if the third dose was administered at 4 years of age or older and at least 6 months after the previous dose. We also note in the dose 3 to 4 column that a fourth dose of IPV is indicated if all previous doses were administered at less than 4 years, or if the third dose was administered less than 6 months after the second dose. Within the figure 3, the high-risk figure, an asterisk has been added to the HIV infection column. This refers the provider to a footnote at the bottom, added to the bottom of the figure. This figure directs providers for additional information regarding laboratory values when under consideration when providing live vaccines to HIV-infected children. This guidance is found in the General Best Practice Guidelines on Immunization and directs the providers to 2 separate areas where they can find the relevant information. Within the footnotes, in addition to the figure changes, the work group is introducing a change to a simplified format of the footnotes. The goal was to remove unnecessary text while preserving all pertinent information and maintaining clarity. This was accomplished by a transition from complete sentences to bullets, removal of unnecessary or redundant language, and formatting changes. I will now show a couple of examples. In many cases, the simplification resulted in a shorter footnote, such as with the rotavirus footnote seen here. In other cases, such as with the hepatitis B footnote seen here, the simplified version is not shorter. However, the reformatting and use of bold text will allow providers to easily find the information they are looking for. This colorful table shows the 2017 HPV footnote and the proposed 2018 footnote. This graphic demonstrates that all of the information provided in the 2017 footnote is maintained in the 2018 footnote. In addition to an overall simplification, there are a few content edits for the 2018 footnotes. Throughout the footnotes, we have replaced the word through within an age range with an in dash. Within the additional information section, we have added text to guide providers as they read through the footnotes. It states within a number range, and there's an example, a dash should be read as through. Additionally, we had text that expressed that ACIP did not express a preference for vaccine product. In light of yesterday's vote, we will readdress this text to make sure that it is clear that this applies to the child and adolescent footnote specifically. Within the hepatitis B footnote, we have added language to clarify the guidance for the birth dose administration. If the mother is hepatitis B surface antigen negative, 1 dose of hepatitis B vaccine should be administered within 24 hours of birth for medically stable infants greater than or equal to 2,000 grams. For infants less than 2,000 grams, the recommendation remains to administer 1 dose at chronological age 1 month or hospital discharge. Within the poliovirus footnote, there is a change reflecting the recently published in January and February of this year guidelines for vaccination of persons who previously received doses of oral polio vaccine. The updated guidance indicates that the total number of doses needed to complete the series is the same as that recommended for the US IPV schedule. The link to the published MMWR is provided in the footnote. Additionally, only trivalent oral polio vaccine counts towards the US vaccination requirements, and guidance to assess doses documented as OPV is provided in the MMWR linked to in the footnote. Within the measles, mumps, and rubella footnote, we have added a placeholder for the language voted on yesterday with regard to use of mumps-containing vaccine in an outbreak setting. We will continue to work with this language with our subject matter experts to ensure it both fits the format of the simplified footnotes as well as true to the recommendation. And within the influenza footnote, The guidance was updated to direct providers to the published 2017-2018 influenza season recommendations. So at this time, we will open the floor for discussion. With the question in mind, does the ACIP approve the proposed edits to the child-adolescent schedule, including the simplified footnotes?
Thank you. Questions and discussion? Dr. Walter.
I just want to thank the work group for all the work to get the footnotes looking much more readable. So I applaud you all.
Absolutely, great work. Other questions, comments? Dr. Freihofer.
Sandra Freihofer, American College of Physicians and practicing a clinician. I think your table giving the brand names is so helpful. And I'm going to encourage my colleagues that take care of adults to look at your table so they can get a little sneak preview of the brand names. And also the way that you have the colors, the bars divided, length going up and down is very helpful when you have so many different columns to look at. It's not as streamlined as the adult schedule, but I think it's easier to read, so very nice job.
Thank you. Other comments or questions? Yes, back there. I'm sorry.
Hi, Sean O'Leary, Pediatric Infectious Diseases Society. Regarding the one about not expressing a preference, when you look at that, my understanding was the ACIP did express a preference for combination vaccines. And so if that's the case, just make sure that sentence reflects that.
Thank you. Yes, we'll revisit that. Thank you.
Other comments, questions? Okay, could I have a motion to approve the childhood schedule? Dr. Kemp?
I make a motion to approve.
Is there a second? Dr. Walter?
I second the motion.
Thank you. Any further discussion, questions? Yes, Dr. Moore.
It's just a brief question as we were working on some of our adult issues over here. I just wanted to make sure that the mumps vaccine recommendation was reflected in the childhood schedule. Was that mentioned?
Yes, it
Great,
was.
terrific. Thank
it
you
was
very
covered.
much. Just wanted to double check.
Thank you. Any other discussion before we vote? Yes. I'm sorry.
Pamela Meharry, the American College of Nurse Midwives. I'd just like to clarify what the speaker said about the 2,000 grams for hepatitis B for the baby. She mentioned that it should be greater than or equal to 2,000 grams.
Yes, that's a typo, and that'll be fixed in the final version.
Good, thank you.
Thank you. Ms. Pellegrini?
Just very briefly, I know you're still working on the mumps outbreak language, but I think the phrase identified by public health needs to be in there, and it's not right now.
Thank you.
Yeah, I think one last go through to assure consistency will happen. Anything else? Any other questions, comments? So we're going to try, one more, Dr. Kimberlin.
David Kimberlin, AAP Red Book. I'm not positive if what I'm about to say is correct or not, but it looks like the general recs definitions of severe versus non-severe immunologic deficiency in someone who's HIV infected may be different from the IDSA recommendations that Lori Rubin led, and then also may be different from the Red Book. I don't know that it matters that much, and I'm not sure if there's definitive evidence, but it may be something to think about going forward, not for this go-round, but for future years, to try to get all those things harmonized into one kind of approach.
Thank you, Dr. Kimberlin. Yes, that's something we discussed at length with the differences between those guidelines and the recommendations. We have deferred to referring to the ACIP-related document for the schedule, since the schedule is meant to reflect current ACIP policy. However, with the new format of the general best practice guidelines, we are able to, as we have evidence and as the SMEs agree, edit that text. And so as those recommendations change or come into line with the other recommendations, we will update that. And this will point to that updated text as well, because it will be updated within the same document.
And if I could follow just with a recommendation, with Dr. Rubin having been a former ACIP member and living as well in the leadership of the IDSA document, he might be a very good person to reach out to just to begin that process. I might not even be seeing it right, but to me it looks like there is daylight between these three types of recommendations.
Yes, thank you. And this is something under consideration by the general best practice guidelines as well.
Okay, Dr. Kroger, did you want to comment?
Yeah, there are discussions underway both with NIH and all of the vaccine-specific ACIP subject matter experts, as well as the HIV folks in terms of how to deal with the issue of the different types of tests that are used, the cutoff parameters, whether you use counts, whether you use percentages, because we want all of that to be harmonized. That's our goal. Currently, the general best practices is harmonized with the MMWR ACIP specific statement that discusses that issue. So there is harmony, within those two documents, but efforts are underway to make sure that all of them are documents, understanding that HIV is focused on surveillance. They sometimes define their categories in perpetuity. When they define people, we don't really want to do that in NCIRD necessarily. If someone's immunocompetent after a point in time, we may want to give a dose of vaccine. At least that's reflected in the vaccine ACIP specific statement. So that work is underway.
Thank you. Ms. Groom.
Hi, thanks. Just a real quick question about the ACIP preference. I don't know that it's actually an ACIP preference, but there is language around American Indian, Alaska Native kids and Hib vaccine. And so that statement, I just want to make sure that it includes that there may be special populations for Hib vaccine for American Indian, Alaska Native kids.
Thank you.
Okay, any further discussion or questions? All right, we are going to try to use our little things again to vote for this.
We have to make a motion.
And no, we've made a motion. You were out of the room. But Amanda's going to lead us through this because it turns out it's a little trickier than we thought.
Okay, so, excuse me. So we want to make sure everybody's on, excuse me, I'm so sorry, channel 71. So you want to press channel 71. And then we'll put the vote open. So if everyone's pressed channel, then 7-1, then we'll make sure everyone is on the right channel. And are you ready to try it again? Okay, it's open. Sorry. Votes. So we are closing the voting. And we will look at the results.
And it passes unanimously.
Yay!
Thank you very much. That makes it a lot easier. Thank you to the childhood schedule. This was really great. And now I think we'll quickly return to the adults schedule. Oh, we'd like to go on to the next. Okay. We're going to go on to Japanese encephalitis vaccine, Dr. Walter, and we will come back to the adult schedule following that. Thank you.
Good morning. Now for a change of pace, we're going to continue our work today talking a little bit about the flavivirus working group and activities of the working group. And these are the current members. I'd just like to acknowledge my ACIP colleagues, Robert Atmar and Cindy Pellegrini, and as well as the other ex officio ACIP liaisons, technical advisors, and the CDC staff. So our work group activities have changed focus a little bit for the flavivirus working group. We had started some work on JEVAX when I started about 2 years ago. We got derailed a little bit by work on a couple of issues, plus a lot of the work on Zika, work on dengue vaccine, and then also the yellow fever vaccine shortage. We've now taken up our work again on Japanese encephalitis. So we have reviewed newly available safety and immunogenicity data for the vaccine. We've reviewed epidemiology and risk factors of JE in travelers. we are reviewing our plans to review the ACIP recommendations for use of JE vaccine in consideration of the updated safety, immunogenicity, and traveler risk data. Lastly, we'll be updating the MMWR recommendations and reports published in 2010. So for today, we have several presentations. First presentation will be by Susan Hills from the CDC. We'll have a presentation on Japanese encephalitis among U.S. travelers. That will be followed by a presentation from Valneva, and that will be given by Christian Toscher. And the conversation there will be looking at JE vaccine post-marketing adverse event surveillance among U.S. military personnel. And then lastly, Susan from CDC will come back and finish up looking at VAERS data and adverse events following JE vaccine reported to the VAERS. And then she'll be coming up with the summary and plans for the work group. Thank you. Susan?
Thank you, Dr. Walter. So Japanese encephalitis is caused by a mosquito-borne flavivirus. It occurs in most of Asia and the Western Pacific, with an estimated 68,000 cases annually. The highest incidence is in rural agricultural areas, and seasonality varies by region. Most infections are asymptomatic, but when clinical disease occurs, it's often severe, with a 20 to 30% case fatality rate and about 30 to 50% of survivors having sequelae. One vaccine, an inactivated Vero cell culture-derived vaccine, which I'll refer to as JEVC, and which is sold as Ixiaro, is the only JE vaccine in the United States. It's manufactured by Valneva. The inactivated mouse brain-derived vaccine, JEMB or JEVAX, is no longer available in the United States. As a reminder about the timelines for recommendations on use of JEVC, in 2009, FDA licensed JEVC for use in adults, and ACIP approved recommendations for the primary series in adults. In 2010, the MMWR recommendations and reports from 1993 was updated and published. In 2011, ACIP approved recommendations for use of a booster dose in adults, and a policy note was published in MMWR. And in 2013, ACIP approved recommendations for use of a primary series in children, and a policy note was again published in MMWR. The JE vaccine work group is currently reviewing recommendations for JE vaccine, as Dr. Walter mentioned, in consideration of the updated safety, immunogenicity, and traveller risk data. A consideration of the recommendations will not be part of my presentation today. However, before presenting information on the epidemiology and risk of JE among US travellers, I'd like to remind ACIP members of the existing recommendations for prevention of JE among travellers. Firstly, providers should discuss with all travellers to JE endemic countries the risk of JE disease and the importance of personal protective measures to reduce the risk for mosquito bites. For some travellers who will be in a high-risk setting, JE vaccine can further reduce the risk for infection. Evaluation of an individual traveller's risk should take into account their planned itinerary, including travel location, duration, season, and activities. In all cases, when making recommendations regarding the use of JE vaccine, healthcare providers should weigh the overall low risk for travel-associated JE, the high morbidity and mortality when JE does occur, the low probability of serious adverse events following vaccination, and the cost of the vaccine. The existing JE vaccine recommendations, which were updated in 2010, are listed on this slide. And they are that JE vaccine is recommended for longer-term travellers who will live in or visit for a month or longer endemic areas during the JE virus transmission season, including recurrent travellers or expatriates who will be based in an urban area but are likely to visit rural or agricultural areas during the transmission season. JE vaccine also should be considered for short-term travellers to endemic areas during the JE virus transmission season if they plan to travel outside of an urban area and have itinerary or activities that increase their risk of JE virus exposure. Travellers to an area with an ongoing JE outbreak and travellers to endemic areas uncertain of specific destinations, activities or duration of travel. JE vaccine is not recommended for short-term travellers whose visit will be restricted to urban areas or times outside of the JE virus transmission season. I'm now going to move on and provide some data on the epidemiology of JE among travellers. In the United States, the mouse brain-derived JE vaccine was licensed at the end of 1992, and this made JE vaccine widely available for the first time. Therefore, this review of the epidemiology of JE among travellers will focus on the 25-year period from 1993 through 2017. To begin with some brief information on JE among all travellers from non-endemic countries, this graph shows the number of cases by year from 1993 through 2017. There were 58 cases of travel-associated JE among people from non-endemic countries published in the literature or in conference proceedings or reported to CDC, with 56 cases included in this graph as the year of onset was not reported for 2 of the cases. There was a limited number of cases reported annually, with a median of 2 cases and a range of 0 to 6 cases per year. There was a small increase in the annual number of reported cases over the period, likely related to an increase in overall traveller numbers and possibly related to increased awareness of and testing for the disease. Among the 58 traveller cases among persons from non-endemic countries globally that have occurred since 1993, 12 cases have occurred among US travellers. All cases occurred in 2003 or later. There was a median of 0 cases per year with a range of 0 to 2. As far as we could establish, none of the travellers had received JE vaccine. Among the 12 cases, 8 or 67% were male, and patients ranged in age from 5 weeks to 68 years of age, with 2 to 4 in each 20-year age group. This slide shows a month of onset of reported US travel-associated cases, with 75% occurring from June to August. While JE risk exists year-round in some countries in tropical regions, the annual seasonal increase in JE in countries in temperate areas occurs over these summer months. Another possible factor contributing to the seasonality of cases might be that a greater number of US travellers may take overseas vacations to Asia during the summer. Among the 12 cases, 2 or 17% died, 3 or 25% survived but had sequelae, and 50% recovered fully. One infant spent 3 weeks in an intensive care unit, but further outcomes were unknown. The country of probable acquisition of traveller cases was Philippines for 4, 2 each in Thailand, Vietnam and South Korea, and 1 each in China and Taiwan. Overall, 8 or 67% of cases occurred in tourists, and 4 cases were in expatriates. The tourist category included 3 persons who were travelling to visit friends and relatives, and also 1 student on a study abroad program. The expatriate category included 1 college professor who worked in the US, but had spent several months overseas working in a JE endemic country. Of the 12 travellers, 8 or 2/3 had travelled for 1 month or longer and should have received JE vaccine based on their longer-term travel but had not. Among the remaining 4 shorter-term travellers, 3 had travelled for 2 to less than 4 weeks and 1 had travelled for 1 to less than 2 weeks. To consider exposure of these shorter-term travellers, we reviewed the itineraries of the 4 shorter-term travellers who travelled for less than a month. 1 spent the majority of their time in rural areas, 2 stayed in urban areas, but it took at least 1 overnight trip to a rural area, and one of these persons also had several day trips to rural areas, and for 1 there was no exposure-related information available. Finally, this slide provides some information to consider estimates of risk for US travellers to Asia. If we estimate risk based on reported US cases and traveller denominator data, there were 12 US travel-associated JE cases in the 25 years from 1993 to 2017, or less than 1 case per year. And there were 4 to 5 million US citizen trips to Asia per year since 2004, based on data collected by the National Travel and Tourism Office. So the overall risk is less than 1 case per million trips to Asia. The risk, of course, will vary based on season, destination, duration, and activities. However, this provides an overall estimate to consider the magnitude of risk. There are limitations to this estimate of risk. Firstly, the figure for the denominator in the calculation is based on number of trips to Asia, as accurate data on the number of travellers are not available. Secondly, the rate of underdiagnosis and underreporting of JE cases is unknown. If we assume 10 times as many cases have occurred among US travellers and have been diagnosed and reported, which is however unlikely, the calculation would be that 120 US traveller cases have occurred over the 25-year period, or about 5 cases per year. 100 to 125 million US citizen trips to Asia have occurred based on an annual number of 4 to 5 million trips per year. And for this scenario, the risk estimate is about 1 case of JE per million trips to Asia. One final question that arises is whether the risk estimate is low because the majority of travellers are vaccinated and not at risk. 2 studies have been conducted that provide some data to address the question of vaccination rates among US travellers. The first was an airport survey conducted in 2007 that showed only 11% of higher risk travellers reported receiving JE vaccine. The second was a Global Trav EpiNet, or G10 study, conducted from 2009 to 2012, which showed only 28% of higher risk travellers were vaccinated during the clinic visit or had received JE vaccine in the previous 2 years. For both studies, the number of lower risk travellers who had received JE vaccine was 2 to 4%. Therefore, even with low JE vaccination rates among US travellers, cases of disease are rare. Thank you.
Thank you very much. Any questions, or should we move on to the next? Okay, I guess we'll go to the next presentation.
Thank you for the opportunity to present this safety surveillance data on our VAERS cell culture-derived G vaccine. My name is Christian Taucher. I head up the Medical Affairs Department at Valneva, which is the company that manufactures the vaccine. So the study that I'm going to present is an active surveillance study for adverse events after immunization with IXIARO, which is the VAERS cell culture-derived G vaccine that's currently licensed in the US. The primary objective was to detect, verify, and characterize rare and potentially serious adverse events. This study was a post-marketing commitment to the FDA, and as such, a list of predefined adverse events of special interest was compiled when looking at the safety profile of both the VAERS cell culture-derived G vaccine as well as the previously available mouse brain-derived vaccine, sprinkled with some events that have been associated or potentially associated with other vaccines. So that was the primary objective. The secondary objective was a data mining exercise basically trying to look at things that happened at a higher incidence rate in a group of subjects that had at least received one dose of IXIARO, and compare this with a population that was comparable. The choice here was to use a population that received at least one dose of the previously available mouse brain-derived G vaccine, or GVAX. If you look at the analysis population, again, this was a database screening study. The population was included male and female active duty members that received at least one dose of IXIARO or GVAX and were of 17 years of age or older. And the enrollment was essentially agreed with the FDA that the first 20,000 subjects that were entered into the database and received one dose of IXIARO would be included, and then in a similar time frame, a much bigger population in that case of subjects who received GVAX was the comparator group. And as already indicated in the primary and secondary endpoints or objectives, we essentially looked at two different categories of adverse events. One set was the list screening for the list of predefined adverse events of special interest. And then the other category was looking at things that happened at a higher frequency in the IXIARO group than in the GVAX group that served as a control group, with the added caveat that at least 5 events needed to be reported in the database. And the event was recorded with either two outpatient visits or hospitalization within a 7 days time window after the vaccination. There's a couple of key characteristics with this military population. Not very surprising, the mean age is relatively young, with about 27 years in the GVAX group and 25 years in the IXIARO group. And also, not very surprisingly, it's a predominantly a male population with over 90% of males in both the control as in the IXIARO group. Looking at the Tier 1 events, this is a bit of a busy slide, but bear with me, I'm going to walk you through. This is how we did the analysis. So we started off with over 21,000 subjects in the database who received at least one dose of IXIARO, and had over 49,000 subjects that received at least one dose of GVAX, and then did the screening for the list of predefined adverse events that happened within a 42 days time window after after the respective vaccination of G vaccine. That revealed at the first screening 182 subjects that did in fact have a code for this predefined adverse events. 4 of those subjects we had to include because they didn't fit the time window of the 42 days. And 5 subjects we couldn't clearly assign to either of the group IXIARO or GVAX because they had both vaccination recorded. That left us with 45 subjects in the IXIARO group that had one of these predefined events, and 128 subjects that were assignable to GVAX. And those are the things that on the next couple of slides is going to show you were included in the analysis for the incident risk ratio. In addition to that initial screening, we tried to get as much of information as possible on those identified events. So we looked at the electronic health records for the date of diagnosis, temporal association, whether or not we had some information on medical history, concomitant medication, and potential outcome. And that served as the basis of information for Data Safety Monitoring Board to assess the causal relationship. When we did do that exercise of looking at the actual more, at all the information that was available, we were able to clearly assign 2 more subjects to that initial screening to the IXIARO group, mainly because they did receive GVAX, but it was outside of the time window of 42 days. And we had to exclude 1 subject that I'm going to mention later on in the analysis as well, because there was just an entering error of the event date in the database. So at the end of the day, we had 46 subjects in the IXIARO group, which had an adverse event coded that was part of the list that we screened for. This is the first view to give you an overview. What are the different things? What is this list? What are the things that we were screening for? I'm going to start with the things that we didn't detect in a database in the XER group. We got ataxia, Bell's palsy, bronchospasm, cerebrovascular accident, CNS inflammation, encephalopathy, Guillain-Barré syndrome, multiple sclerosis, myelitis, neuropathy, transient ischemic attack, and acute disseminated encephalomyelitis. So let me explain a little bit what you can see here. You did notice that the study population was different in the XER group and the GEVAX group. We had much more subjects in the database for the GEVAX. So what you need to do in order to be able to compare the two groups, you need to look at the incidence rate per 1,000 patient years, and that you could compare if there in fact was an event in both group, and then also calculate the incident risk ratio and then test for statistical significance if that difference actually was statistically significant. After that explanation, let's look at the things that were detected in the database when we looked at the XER group. There were 6 cases with the code for convulsion, 3 cases for delayed hypersensitivity or serum sickness. There was 1 additional case here that we added when we looked at the electronic health forms, 2 cases of anaphylactic shock, 2 cases of angioedema, again with an additional one that we identified after looking at the electronic health forms, 29 cases of neuritis, 2 cases of meningitis, and that 1 case of ptosis was the one that actually happened 4 months before the XER vaccination. If you look again here, as mentioned earlier, the incident risk per 1,000 patient years, you can see that numerically there are some differences. If you look at the incident risk ratio, if it's above 1, it is basically an indication that numerically it happened at a higher incidence in the XER group. Well, if it's below 1, that means it happened at a high incidence, at least numerically, in the GEVAX group. But if you look at the very right column, you can see that at the end of the day, none of the differences that you see in the slide were of statistical significance. However, since we did find a limited number of events of special interest, and after discussion with the G working group, I want to give you a bit more information of the things that we did find, the ones in the black in the next couple of slides. Looking at the 6 cases of convulsion, you can see that 5 of them had the same coding, other convulsion, and 1 had the code of epilepsy unspecified. The time of onset was between 4 or 5 days to a bit over a month. A couple of concomitant vaccination was given. In some of the instances, rabies, influenza, typhoid, smallpox, and anthrax vaccination. In the database, for none of the 6 events, a causality was specified or suspected, but rather comforting, at least in 3 out of the 6 convulsion cases, a second dose of XER was given after the event was recorded, with no further event detected in the database after that second dose. Looking at the 4 cases of delayed hypersensitivity and serum sickness, again, all of the 4 had the same code. The date of onset was in 2 instances on the day of vaccination. 1 case happened or was detected in the database 1 week after the XER vaccination, 1 month. In 2 instances, anthrax vaccine was given concomitantly. And in this case, in 1 out of the 4, the database, the person that entered it actually speculated that the causality might be linked with XER, even though a second dose was given in that instance with no further report of a similar event after the second dose. The same is true for additional 2 of these 4 cases of serum reaction. Anaphylactic shock, we had 2 cases in there. One was coded anaphylactic shock due to serum, the other anaphylactic shock. 1 date of onset was 21 days after the second XER vaccination. Anthrax was given concomitantly. Nothing was specified more in the database. And since it was the second vaccination, there was no record of a third dose given. For the other event, we had a bit more information available. That was a patient presented in an emergency department 2 months after the first vaccination with dermatitis, in particular full body rash, itchy, and shortness of breath. The patient denied taking new foods, soaps, or detergents. Patient was prescribed prednisone, Benadryl, Zantac, and the diagnosis of anaphylaxis was made. Unfortunately, we don't have any more information on that particular case here. Coming to angioedema, 3 cases detected in the database, date of onset roughly 2 to 3 weeks after the first XR vaccination. In one case, rabies vaccine was given concomitantly. Causality was specified for one of the cases, but not linked with XR, but with a bee sting. And in 2 out of the 3 cases, the second dose was given with no further similar event recorded in the database. Overall, as I told you at the procedure in the study, we had out of these 46 identified cases within the database, 12 adverse events that were judged, assessed by the Data Safety Monitoring Board of the study, at least as possibly related. 2 out of the 6 convulsions, 3 out of the 4 serum reactions, 1 out of the 2 anaphylactic reactions, and 2 out of the 3 angioedema. Looking at the second category of adverse events, again, let me remind you, those were the things that were suspected to happen at, were tested to happen at a higher incidence in the XR group, with at least 5 cases detected in the database. And what you can see when you apply that filter is that all that's left is anthrax unspecified, which is potentially coding error, and they meant to give anthrax vaccination given, and the other was deviated nasal septum, where, at least the Data Safety Monitoring Board failed to see a causal relationship. This brings me to the conclusion. In a population of more than 20,000 US military personnel that received a good 36,000 doses of XR, the screening for predefined events that potentially are serious did not reveal any statistically significant increased incidence rates compared to the control group, which was a population that was given GEVAX. The data mining effort, looking for anything that happened at a at a statistically significant higher incidence rate compared to the GEVAX population, also didn't reveal any events with the potential causal relationship with XERO. No safety signal have been detected. And overall, this fits rather well with the established clinical profile that was seen in the clinic development and also the post-marketing experience, which I think Dr. Hills will give you a bit more insight in her following talk. In conclusion and in summary, the benefit-risk evaluation with that additional information from this study remains positive and unchanged compared to that at the time of authorization. Let me finish up by saying thank you to our collaborators at the Department of Defense, most foremost our study PI, Dr. Margaret Jacobon and Dr. Limon Collins, and our main contact point, the study coordinator, Tracy Vector. Thank you very much.
Thank you. Any questions for Dr. Toucher? Yes, Dr. Lee.
So I have 2 questions. One is, how did you determine causality? I realized there was this a board that probably determined it, but it's interesting because only 1 of the 6 actually had a medical history of convulsions, and I find it very unusual that an adult would have a sudden onset of convulsions in any period after a vaccination. And then I have a second question for you.
Okay, that's clearly a limitation of that study. It's a database screening effort, and you need to work with the information that's available. And as you can see, there's very limited information available. So the causality assessment essentially was based, heavily on the temporal association with the events.
So 2 out of 6 were actually determined causal as opposed to 5 out of 6 because they fell outside of a risk window, or because it was determined by causality in the medical record?
Can you remind me which adverse event are you talking about?
Convulsions?
Convulsions. Yeah, I think the fact that the second dose was given was an element and the temporal association. I'd have to go back. Yeah, I don't have more details in my head, to be honest, on that one.
And then my second question relates to the unanticipated adverse events. It seems the tier 2 criteria on slide 3 are fairly strict. And just wondering about if you're really trying to identify unanticipated adverse events, if you could loosen them. I noticed there was an and. So not only did you require 5 or more ICD-9 diagnosis codes, but you also required 2 outpatient visits or 1 inpatient hospitalization, and that seems very unlikely to pick up unanticipated adverse events. So it seems like in that setting, it might be good to go broader and loosen the criteria.
Yeah, I can, yeah.
Other questions, comments? Okay, back to Dr. Hills. Thank you very much.
Thank you. So I'm now going to present findings from an analysis of adverse events following JEVC reported to the Vaccine Adverse Event Reporting System, or VAERS, from 2012 to 2016. As a reminder, and to provide the context for this review, distribution of JEVC for adults aged 17 years and over began in May 2009, and in mid-2013 for children and adolescents aged 2 months to under 17 years. In 2015, a review was completed of VAERS reports for adults who received JEVC from May 2009 through April 2012, covering the first 3 years post-licensure. The objective of my presentation today will be to summarise the JEVC VAERS reports collected since that time from May 1, 2012 through April 30, 2016, which includes the period when the vaccine began to be used among children. As a reminder, VAERS is a passive surveillance system for reporting of adverse events following immunisation. Manufacturers, healthcare providers or vaccine recipients can submit reports using a standardised form, which collects data on patient demographics, the vaccination and a description of the adverse event. Descriptions are coded with Medical Dictionary for Regulatory Activities, or MEDRA preferred terms. The causal relationship between vaccination and reported events usually cannot be determined. Reports are classified as serious or non-serious according to the FDA regulatory definition, which defines a serious event as one that is life-threatening, results in death, a persistent disability or incapacity, a congenital anomaly, hospitalisation or prolongation of an existing hospitalisation, or another medically important condition that requires medical or surgical intervention to prevent one of these outcomes. An adverse event report was excluded if it occurred more than 60 days after vaccination, it was a local reaction contralateral to the site of administration of JEVC, the vaccine was administered inappropriately but no adverse event occurred, or the symptoms were clearly related and unique to another co-administered vaccine. An important factor for consideration of JE vaccine adverse event data is that a high percentage of vaccine doses are distributed to the US military, which impacts the demographics of vaccine recipients and profile of co-administered vaccines, which in the military often includes vaccines like smallpox and anthrax. We use the following definitions to classify particular events. Hypersensitivity events were classified as anaphylaxis if they met level 1 or level 2 of diagnostic certainty using the Brighton collaboration case definition and occurred within 2 hours of vaccination. For non-anaphylactic hypersensitivity events, we used a modified Brighton definition developed by expert consensus and used in a previous JE vaccine VAERS analysis. We divided non-anaphylactic reactions by interval between vaccination and onset, designating events under 2 hours as immediate and between 2 hours and 14 days as delayed hypersensitivity. Neurological events were classified as central or peripheral. For central neurological events, we used Brighton collaboration case definitions for events such as aseptic meningitis, encephalitis, acute disseminated encephalomyelitis, Guillain-Barré syndrome, or generalised seizure. Reports consistent with paresthesia and peripheral neuritis were classified as peripheral neurological events. To enable calculation of incidence rates of adverse events, Valneva provided total doses distributed by month. However, no data were available on doses administered by age and sex. This table shows the number and rates of adverse events. As you can see in the middle column, there were 119 adverse events during the 4-year period of this analysis, including 9 serious events and 110 non-serious events. During this time, over 802,000 vaccine doses were distributed for an overall adverse event reporting rate of 14.8 events per 100,000 doses distributed. The rate of serious events was 1.1 per 100,000 doses distributed, and for non-serious events was 13.7 per 100,000 doses distributed. The distribution of adverse events by sex and age group is shown on this slide. Overall, males accounted for 61% of the adverse event reports. Among age groups, the majority of reports were for persons in the 17 to 39-year age group, 66% of all reports. The higher percentage of cases among males and the high number of cases in the 17 to 39-year age group is likely in large part related to the administration of substantial numbers of JE vaccine doses to young adult males in the military. There were 11 adverse event reports for children and adolescents under age 17 years. As mentioned, there were no data on doses administered by age group available to calculate rates of adverse events in children. In considering whether adverse events occurred after a first, second or subsequent dose, the data showed 53% were for persons receiving a first dose, 22% were after a second dose, and 8% were after subsequent doses. The dose number was unknown for 17%. We considered adverse events among persons receiving JEVC alone or JEVC concurrently with other vaccines and looked at serious versus non-serious events. The majority, 80 or 67% of all adverse events occurred following JEVC co-administered with other vaccines, including 8 serious events. 1 serious and 38 non-serious events occurred following administration of JEVC alone. This slide shows adverse events following JEVC by event type. Overall, as shown in the top row, 24 or 20% of all adverse events were classified as hypersensitivity events, including 2 serious events. 11 or 9% of reports were classified as neurologic, including 1 serious event, and the majority, 84 or 71%, were classified as other event types, with 6 events being serious. Among the hypersensitivity events, 1 was anaphylaxis, 7 or 30% were immediate, and 15 or 65% were delayed hypersensitivity events. Of the 2 serious hypersensitivity reports, 1 was a report of anaphylaxis and the other of immediate hypersensitivity. The anaphylaxis event was in a 19-year-old female and occurred around 25 minutes after receiving anthrax, typhoid, yellow fever, and JE vaccine. The serious immediate hypersensitivity event was in a 23-year-old male with onset 15 minutes after receiving anthrax, typhoid, and JE vaccines. For the 11 neurologic adverse events reported, 2 were central, both of which were seizures, with 1 reported as serious. 9 were peripheral events, including 6 events described as paresthesias, 2 as somatosensory events, and 1 as sensory neural hearing loss. The serious seizure was in a 15-year-old male and occurred 7 days after receiving the second dose of JE vaccine and third dose of rabies vaccine. Subsequent seizures were also reported. There were 84 other non-hypersensitivity, non-neurologic events. These included 23 local reactions and 61 other reactions. The most frequent descriptors for these other events were rash, headache, dizziness, nausea, and fever. Among these other non-local events, 6 were categorised as serious. The 6 serious other events included 1 case each of sudden cardiac death, cardiomyopathy, myocardial infarct and acute myocarditis, angina pectoris, a systemic febrile reaction with acute vaccinia syndrome, and acute kidney injury and myopathy. As you can see in the final column, most occurred following co-administration with other vaccines. The only event that occurred following administration of JEVC alone was in the patient in row 1, a 42-year-old male who 8 days after vaccine administration suddenly collapsed while running, and final cause of death was recorded as sudden cardiac death due to ischemic heart disease. Finally, this table shows a comparison of reporting rates from the previous analysis of VAERS data, shown on the left, and our current analysis on the right. The rates found in the analysis are similar to or lower than those found in the prior analysis. Overall rates of adverse events were 15.2 per 100,000 doses distributed in the previous analysis and 14.8 in the current analysis. The hypersensitivity event rates of 3.0 per 100,000 doses and neurological event rate of 1.4 per 100,000 doses were lower than the previous analysis. In conclusion, the rates of total, hypersensitivity and neurologic adverse events have not increased compared to the previous VAERS analysis. Few adverse events were reported in under 17-year-olds, although administration data by age group are not available to calculate age-specific rates, and it's likely low numbers of vaccines are administered to children. Finally, VAERS data suggest hypersensitivity and neurological adverse events occur but are uncommon. With more than 800,000 doses distributed during this review period, the data support the good overall safety profile of JEVC. Thank you.
Thank you. Questions for Dr. Hills? Comments? Yes, Ms. Pellegrini.
Sorry. One question and one quick comment. The question is, was any of the data related to pregnancy? Did you look at pregnancy?
There was one report of administration during pregnancy, but no adverse event.
Thank you. And then the comment is, I just wanted to point out that behind our last tab, there are a couple of letters commenting on this. You have that? Okay. And but in looking at that, there was a request in the first letter that 2 others be included, and I only saw one of them.
Yes, so we are still looking for the letter from 2013. We will send it around to the ACIP members. So there's 2 letters in your packet from, it's not in my packet actually, but it's from a travel.
It's from American Society of Tropical Medicine and Hygiene there.
Thank you. And they sent letters to ACIP in 2013, 15, and then one a couple weeks ago. So you have the one from 2015 and 2017, and we'll send around the one from 2013.
Thank you. Any further questions? Okay, Dr. Hills.
So I'm now going to present on behalf of the JE Vaccine Work Group our summary of the data presented today. I'd also like to update ACIP on future plans of the JE Vaccine Work Group. As a reminder, when the JE Vaccine Work Group was reformed in March 2015, the objectives were to review newly available safety and immunogenicity data for JEVC, review updated data on the epidemiology and risk of JE among travellers, review the ACIP recommendations for use of JE vaccine in consideration of the updated safety and immunogenicity and traveller risk data, and prepare a revised MMWR recommendations and reports to update the document that was published in 2010. To summarise the data that have been presented today, I'd first like to present our conclusions on the epidemiology and risk of JE among US travellers. Our review indicated JE is a low-risk disease for US travellers. Only 12 cases were reported in the 25 years from 1993 through 2017. And based on US citizen trips to Asia, the incidence is less than 1 case per million trips to Asia. The estimate risk remains low at about 1 case per million trips, even if there is substantial underdiagnosis, and 10 times as many cases occurred as were diagnosed and reported. The majority of US traveller cases occurred in longer-term travellers, and the remainder for whom information was available had rural exposures. Finally, there's been no apparent change in the risk of JE for travellers compared with an assessment at the time JE vaccine recommendations were considered previously in 2010, which also estimated a risk of less than 1 case per 1 million travellers. The second topic that was presented was JEVC adverse event surveillance data, including 1 post-marketing surveillance study and a review of recent VAERS surveillance data. Our workgroup summary was that active surveillance among more than 21,000 US military personnel vaccinated with JEVC showed no statistically significant increased incidence rates for selected neurologic or hypersensitivity events compared with the personnel vaccinated with the previously available mouse brain-derived JE vaccine, JEVAX. An updated analysis of passive surveillance data collected through VAERS in the period 4 to 7 years post-licensure, when over 800,000 vaccines were distributed, showed that rates for total, hypersensitivity and neurologic adverse events were not higher than rates in the first 3 years post-licensure. There were a low number of reports among children, although age-specific rates could not be calculated. Therefore, overall, rare, serious adverse events are reported, but these recent data support the overall good safety profile of JEVC and suggest rates of serious adverse events are not higher than rates for JEMB. To complete the remaining ACIP JE vaccine workgroup objectives, the following items will be addressed at upcoming ACIP meetings. A review of the ACIP recommendations for use of JE vaccine in consideration of the updated safety, immunogenicity and traveller data that have been presented to ACIP at this and previous meetings. A cost-effectiveness analysis of JE vaccine for US travellers. A grade analysis to update the analysis performed in 2013 when paediatric JE vaccine recommendations were considered, and presentation of a draft of an updated MMWR recommendations and reports. Thank you.
Thank you. Questions? Go ahead, Dr. Lee.
Thank you. Thank you for that overview. That was really helpful. In looking ahead to what we need to think about for decision-making, a comment and then I guess a question. One is that I do believe it seems like that the comparative rates compared to prior use of the older vaccine doesn't look very different in passive surveillance data, but I think that it seems like it's an underestimate, and I wonder if there can be more robust safety data presented to present accurate sort of adverse event rates following this vaccine as you're considering this in both a grade analysis and in cost effectiveness. So I guess my question is that upcoming, or is there going to be more information presented in the cohort of individuals who receive this vaccine?
So I do have a slide that compares the rates of the mouse brain-derived vaccine and JEVC vaccine, so I can present that at a future meeting. That is based on VAERS reports, so that's the data that we have available. Additional to that, we have the data that were presented today from the post-marketing surveillance study and the initial data that were prior to vaccine licensure.
So I guess I would suggest perhaps that a more detailed review of the study coming out of the DoD population would be considered by the working group, and also just recognizing the underestimation of the burden of disease just due to perhaps lower detection, also understanding how that might influence decision making as well on both ends.
Yeah, I'd like to second that actually, because I think that although you stated in your slides that the adverse events were not more frequent than the disease itself, that's actually, I think the serious adverse events were about 1 per 100,000. So it's a fairly significant serious adverse event rate.
Yeah, I just need, as a clinician and a local public health person that doesn't deal with travel medicine or this vaccine at all, I need to see if I got this straight as far as the public health implications in particular. It's a large number of people who are traveling who might be at risk, and a very small number of them get very, very serious consequences. And that, in my mind, looks a little bit like meningitis, meningococcal meningitis from that point of view, but there's a lot of implementation issues that are very, very different, and vaccine performance and adverse events that are quite different. Am I just in a real ballpark? Am I in the right ballpark when I say those things?
Thank you for...
I think your comments are correct. I mean, it's a disease that when you get it, it's not good, but it's very rare and very rarely occurring in the traveler. I mean, for the average person that gets it, they can get very mild illness, but when they get it and they get severe illness, it's bad. So, but you can get infected and not get a mild infection.
I mean, I think that's why the adverse event rate issue is so important in this particular vaccine. Dr. Atmore.
But the million travelers is, the vast majority of those travelers are not at risk and it wouldn't be indicated for them. So to say it's less than 1 per million travelers to Asia really doesn't accurately reflect the people for whom it might be indicated. It's still going to be a cost benefit, and it'll be interesting to see an economic analysis of that. But
Dr. Kemp.
I'm just struck by, the vast majority of these events occurred with multiple vaccines. How do you separate that out? I mean, to me, that makes these data, they're helpful, but I really have no idea.
Some of them, especially the cardiac events, can be pretty much attributed probably to smallpox vaccines.
Yeah. Right. Dr. Reingold.
So to save me the trouble of looking it up, could you remind me what we know about the efficacy, duration of protection, and need for revaccination?
Yeah. So it's a 2-dose schedule, 0 and 28 days, with over 90% seroprotected at 1 month, which continues. The rates drop through about 12 months, which are variable rates in different studies, about 60 to 85% at 12 months when the booster dose is recommended. The booster dose, we have data through 6 years, which shows good rates of seroprotection over that period.
Dr. Massonia.
Yeah. Now that we've seen the adverse events data, I have a question about your last presentation, which is in your initial case series, one of the things that struck me was that a lot of those individuals either were in your category of should have been vaccinated or should consider being vaccinated. And so do you know more about why they didn't get vaccinated? And in the considered category, were those people considered? Was there an offer of vaccine that was refused? In other words, were those groups that we should have been preventing with our current recommendations?
Unfortunately, we don't have that data. We have tried to follow up the cases as much as possible through the local health state or local health departments to ask those questions, but it's often difficult to get additional information, so unfortunately I don't have that.
Dr. Romero.
Dr. Walter already made my comment about the smallpox vaccine in association with the cardiac disease.
Dr. Szilagyi?
Yeah, quick question. Can you remind me why we can't get rates in children? Why we don't have denominators of
Especially with many states requiring, notification to the registries?
So I don't think JE vaccine would be part of that, and the doses distributed are only available by doses distributed. We don't know who they're administered to, and therefore what the age or sex of those who they're administered to are.
Dr. Sun?
You might have mentioned this, but would you remind us again, the numbers that you give, are they including both civilian and military travelers?
Yes, they're for both. The adverse event rates?
Yes.
Yes. And we know that a majority of doses, probably around about 80%, are distributed to the military for JE vaccine.
Dr. Walter?
One other comment in response to Dr. Szilagyi. A lot of travel vaccines are given, particularly in travel clinics, and not by providers who would use a registry, so that information is oftentimes not available.
Dr. Belongia?
Can you just remind us, what is the current DoD policy? Is everybody who's deployed to Southeast Asia vaccinated with this? And what are they doing currently?
I believe it's for vaccination to the relevant destinations, but I will ask Eric to comment.
Sure. So currently the policy is for active duty members who are stationed on the Korean Peninsula in Japan for 30 days or greater to get JE vaccination, and that includes all services. It's also recommended to other beneficiaries, and then it's based on risk for the other areas within the endemic JE areas.
So your analysis of the safety surveillance study was through 2011, I think, so there should be a lot of additional data potentially available to look at in a larger follow-up.
The current analysis was through 2016, April 2016.
Okay.
The previous one was up through 2012.
Let's clarify, the VAERS analysis was through 2016. The analysis of the DoD database was through 2011.
That's what I was referring to.
But that was a post-marketing commitment of the company to FDA. So those are not data that we routinely have access to. And there's really not going to be additional safety data other than if the DoD wants us to look at those data beyond, but there are significant limitations we're not going to get more detailed data that we have, and it's going to be very hard to separate out, as was brought up, concomitant vaccination.
Yes.
They all are receiving multiple vaccines, including some fairly reactogenic vaccines. So it's going to be hard to separate this out further.
Yep. Dr. Lee?
So in the DoD database, does it also include spouses, children, associated members of the military?
Is your question regarding the electronic health records?
Yes, to see if that might be, are they also getting vaccinated if they go as a family? And do you have information on their family members as well?
So if they are vaccinated based on the recommendation, then, and that is done within a military treatment facility, that would be captured within the military's electronic health record, yes.
So it would be great, just to follow up on Dr. Belange's point, to suggest a collaboration in this instance to be able to go up to current data and actually capture information on both kids and adults, because the profile in kids might be very different as well.
Agreed. There's a pretty small number of doses that are administered in children, but if we could sort that out, I agree.
Well, that's why I was wondering whether the adverse events is actually higher in children because of the small number of doses given. We just don't know the rates.
Ms. Pellegrini?
And just as a note, it would be a little cleaner because the kids shouldn't be getting smallpox or anthrax.
At the microphone.
Hello, this is again Christian Taucher from Van Leeuwen. Just to clarify and add to that, we had similar consideration when it comes to the dependents, and we did already start discussions with the DoD to find out what's the vaccination rate of the dependents and whether we get some sort of collaboration going. But the reality, at least our current status, is that we don't have that information available or even easily accessible in the database. So we are pursuing this opportunity, but right now we didn't get far. So if we can, if you can support it there, we'd be up to do it. Thank you.
Thank you. Also at the microphone.
Yes, and it's John Allen with Valneva. There's unpublished data from a study from the Department of Defense that in 2015, 10% of the Air Force dependents that live in Asia are currently receiving Japanese encephalitis vaccination.
Thank you. Okay, any further comments, questions? Okay, thank you very much to the flavivirus group. We're going to move back now to the adult recommendations, and I hope that we'll be able to proceed to a vote, and then we might actually get our break almost on time.
So adult immunization schedule redux. Okay, so I will revisit three topics. The first is on the zoster vaccination. Second is the Tdap, and the third is the MMR in outbreak settings. So first the zoster. We went back to the drawing board and literally redrew the schedules. This is figure 1, the recommended schedule for adults by age group. And as you can see here, the ZVL on the left-hand column under vaccine, there's there's a row for ZVL and another row for HZSU. I just want to let you know that the order will be reversed because the preferred vaccine is HZSU. I just couldn't do that given the fixed background on the schedule. So like I said, ZVL and HZSU will be flipped around, and so ZVL will obviously remain the same. HZSU will include in that title preferred, and in the indication bar, which will go from 50 years and older, will contain the information 2 doses. For the more complex schedule, the recommended schedule for adults based on medical condition and other indications. Again, on the left-hand side, we see list of vaccines. There's the ZVL and HZSU. And I repeat that we're going to flip the 2 vaccines around. And so ZVL will remain the same. HZSU, actually, it won't remain the same because there will be a change in the indications bar to say that it's recommended for persons aged 60 or older, 1 dose. For the HZSU row, under the vaccine column, it will say preferred, and in the indication bar, it will say 2 doses for age 50 or older.
Can I just pause before everyone starts raising their hands at once? David, can you go back a slide? And I think the issue is that these look like 2 separate vaccines, which they are, but that they're both zoster vaccines. And so we need to somehow make that not 2 rows that seem like they're independent, but 2 rows that somehow say zoster on the left, and then maybe indented or something.
Or a dotted line.
Right.
I mean,
Or dotted line.
or a dotted line, something so that it looks like the same.
Right.
But we couldn't do that here because of the fixed picture.
Right, but I mean, the concern is people think it looks like you're supposed to get ZVL. I mean, because of the way the abbreviations come out, it's not obvious that they're both zoster vaccines. And so you guys like the idea, but you want us to format it in a way that makes it clearer that they're combined, which I don't think he could do because of the graphic constraints.
Right. What we could do in free drawing it, as opposed to using software, is we just basically sort of divided that row into 2 with a dotted line, and then, that way it's clear to anyone looking at it that these are not like 2 separate vaccines. They're all in the same category, and it's clear which is HCSU is preferred over ZVL.
And we can make sure that the final graphic version is always sent to all of you anyway for final approval, so.
Okay.
Dr. Duchin. Thank you for those suggestions.
Yeah, just a quick comment. If we do that for zoster, we might consider being consistent with pneumococcal and meningococcal as well, which have multiple vaccines for the same disease.
Pneumococcal, you do get both. and also, I think meninges, they're different vaccines. It's a little bit different. Any other comments? At the microphone, I believe.
Hi, this is only my second ACIP meeting. I have a general comment and
Is this public comment?
Yes.
Okay, could you wait 1 minute? We haven't quite gotten to that.
Oh,
but we will before the vote. I apologize. I think the gentleman who was there before, is this also public comment?
It's just comment about the recommendations. I have the footnotes.
Could you introduce yourself?
Wayne Hashey, Protein Science, now a Sanofi company. Under the influenza section, general comments, options for adults, it lists a number of vaccines, high dose, adjuvanted, and intradermal IV. It does not include RIV, which is also a vaccine limited to the adult population. Also presented here at the ACIP that showed increased effectiveness in the 50 and above age group.
We do have RIV in the footnotes.
Not in the ones that were passed out today.
If you're talking about RIV not being in the figures, that's something else. But in the footnotes, we have RIV specifically mentioned.
Under general information, available options for adults, RIV is not listed, at least on the handouts that you have out front.
We will confirm that it's there.
Yeah, we'll confirm.
And if you would like to send an email to the ACIP at cdc.gov web box to make sure that you're clear, we can double check as well.
Before we go to general comments, I mean, we interrupted David in the middle of going through the changes so that we could clarify that.
I just want to be sure that we're all on the same page about zoster vaccine. So we all agree, we know what that's going to look like. Okay, next.
Okay, next. This is the in the blue box is what was voted on yesterday regarding measles-containing vaccine in outbreak settings. So the language in the footnote will have an added bit that it says adults during mumps outbreak and identified by public health to be at increased risk if previously vaccinated with 1 or 2 doses of mumps-containing vaccine, they should receive 1 additional dose of MMR. So the difference between what I have here and what I presented earlier is previously vaccinated with 1 or 2 doses of mumps-containing vaccine. Regarding Tdap.
Wait 1 second. Are there any comments on this one? Dr. Moore.
Thank you. Just a quick question. We don't want to give the impression that those with 0 doses shouldn't also get a dose. But as long as we're clear on that, we just want to make sure we're not creating anyone's confusion.
Okay. All right. Next.
Okay, next is Tdap. The policy guideline from the ACIP specifically states that 1 dose of Tdap is indicated for adolescents and adults, except for pregnant women. So there is a guidance for use that ACIP recommends that adults, older adults, get Tdap, as well as healthcare workers get the Tdap if they weren't vaccinated earlier, including a dose as an adolescent. So, questions on that?
Any further questions about Tdap? Dr. Hunter?
Yeah, I think I sent this to you in an email just the guidance for clinical use, and I'm still not clear whether or not you get a second dose of Tdap if you had one as an adolescent.
It's no. So unless you're pregnant, all individuals are required to get a single dose of Tdap, including healthcare workers, adults, and older adults.
That's the way I was reading it. I just wanted to make sure.
Okay.
So if we go back to the discussion earlier, healthcare workers, if they received one dose of Tdap, then they are good, like the other populations except for pregnant women.
I think this clarifies the issue, but I think the pertussis group, because I don't remember it ever being discussed on the pertussis group, is that adolescent group is now aged and entering healthcare, whether we want to at some point make a recommendation for one dose as an adult, but that's never been discussed, but I think it should be brought up and discussed explicitly in the working group.
So we can put that in the parking lot, for sure. Other comments, Dr. Freihofer?
The way that reads is it says adults age 65 and older, and then the descriptive part is in the parentheses. So it would mean grandparents, child care providers, and healthcare practitioners that are 65 and older.
Yeah, Dr. Freihofer, there is another spot where it is clear that healthcare workers should read it. We apologize for putting up the wrong section of the guidance, but there's guidance available that describes that all healthcare workers. It was in the one on general adults.
Any additional questions or comments on the adult schedule in general? Okay, are we ready for, I can't remember whether we made a motion before. I think we did. One more, no, we're going to have public comment, but I don't think anyone made a motion. Okay, could someone move to accept the adult schedule?
I move to approve it.
Thank you, Dr. Belange. Is there a second?
Second.
Dr. Romero, fine. Okay. Any further discussion before we move to public comment?
Yeah, it's Paul Hunter. The wording of the footnote for the mumps, MMR for mumps outbreaks, where it says 1 or 2 doses, I think that we need to make sure that says less than or equal to 2 doses to get the 0, 1, and 2 doses.
That's
Okay.
a great suggestion.
Okay, good. I'd like to ask the person at the microphone to identify herself and make comment.
Hi, my name's Andrea Woodruff. I had a couple of comments. For a healthcare worker, how are they going to prove evidence of a past infection of chickenpox? Or I didn't understand how. Are they going to get titers beforehand? Is that recommended? I didn't really understand that. And then I also am getting a lot of feedback about the pregnancy with Tdap and influenza. A lot of the pregnant women who have contacted me are very concerned because when they go to the CDC webpage, they only see a couple of studies. It's not in the PI that it's safe in pregnancy. They go to the CDC website, they only see a couple of studies, and it only shows that the baby survived the pregnancy. It doesn't go on to show if there are long-term disabilities. And I'm just generally getting a lot of pushback from this, and I just want to let you guys know because it really puts everyone in a bad spot when the public is pushing back. Thank you.
Thank you very much for your comment. Is there further public comment?
Hi, I'm Laurel Wood from IC, but my comment won't impact the vote. It is about adult immunization, but I'd be glad to wait until after the vote. Go ahead. Okay. The Immunization Action Coalition is very aware, as all of us in this room are, about the difficulty of adult immunizations and the challenges that we're all seeing with that. Because of that, I wanted to let you know about a wonderful new resource that we've just published called Vaccinating Adults, a Step-by-Step Guide. We were able to do this with support from CDC, and we're really grateful for that. Folks from CDC also have reviewed early versions of the guide. But this book is available. It's an update of our 2004 version, of which we've had over 500,000 downloads off of our website of various chapters. So clearly, There's still lots of confusion about adult immunizations. We've updated this to be a great resource and easy-to-use how-to guide for providers who are either already giving adult vaccinations or who would like to who haven't been giving immunizations or would like to enhance their services. The practical steps in the guide include how to set up for services, how to store vaccines, who to give vaccines to, how to administer them, and most importantly, we have a lot of information about how to bill for vaccines and financial information. It also includes many, many web addresses to help people stay up to date with current information. So I wanted to let you know that the ACIP members and the liaison members will be receiving a complimentary guide in your offices soon. We thought you wouldn't want to have to carry them with you today. But also for everyone else, within the next 1 to 2 weeks, we will have a website available at immunize.org/guide, where people will either be able to order a hard copy of the book like this, or they will be able to download for free all the pages, print them, do whatever they'd like, and share them with others. So we hope this will be a helpful addition to what is clearly a lot of confusion about adult immunizations. We thank CDC and we thank you for your attention and hopefully your ability to help us share this with providers around the country. Immunize.org/guide. Thank you.
Thank you very much. Okay, I would like to now move us to a vote and remind us again.
Yes, so if everyone would please press channel and then 7-1, and we're pulling up the voting slide, and we will tell you it is now open. Will everybody please press one more time? Sorry. The voting is still open. Okay, great. The voting's now closed. Not too bad. What?
You know, it takes a little while to teach old dogs new tricks, but we're getting there. Thank you all very much. We've unanimously approved the adult immunization schedule, and thank you everyone for your really insightful and attentive comments on this. It wasn't easy, but I think we made the best possible product, so thank you. We're going to take a break right now for 15 minutes.